So, all right, Dr. Das, I think
Yeah,
you can go ahead and get started.
that sounds great. Dr. Rose, thanks for that talk. I felt like I learned some anatomy again, so I appreciate that. We already actually have some fantastic questions, so we'll work our way down, and then of course, happy to take them as they come. So the first question was, what are the definitive methods to determine whether someone has positive receptors? And I believe the receptor here that they're talking about is somatostatin receptor. Um, did you guys want to take that, or you want me to take that?
I mean, I guess we can probably all chime in. I think the most clinically relevant one is going to be using receptor-based imaging, so dotatate scans. We do occasionally look at them on pathology, but mostly for research purposes. So what's most clinically relevant, I think, is going to be whether or not their dotatate scan lights up.
Yeah, I completely agree. I think previously we actually used to sometimes have to look at, immunohistochemistry or to actually look at somatostatin expression. But the beautiful aspect about the dotatate is it gives you extent of disease, but also the functionality and shows us expression. So certainly would agree with that. The next question is for a patient with a well-differentiated pancreatic neuroendocrine tumor, post first-line, second-line therapy, and PRT. After 12 years, does it make sense to re-challenge on older therapy or to proceed to a clinical trial upon progression? So I think I'll start with this one, if that's all right. I think a lot of it depends on tempo of disease and burden of disease. So we certainly know that we can actually recycle our therapies. So particularly for patients with pancreatic neuroendocrine tumors, the one that I think of is capecitabine and temozolomide. So usually when we administer capecitabine and temozolomide to patients, we give it for finite cycles. So usually give 4 to 6 cycles at a time to preserve patients' bone marrow. And if patients are responding, we actually oftentimes take them off that therapy. So, as long as the tumor hasn't grown through something like the capecitabine and temozolomide, that is certainly an option. There's some data emerging with repeating PRRT. Now, this is still experimental in that some insurances don't cover repeating PRRT, but I think as long as a patient originally derived benefit from PRT, now what that definition is still a little bit debated, but we think about that at least a year of benefit from PRT, it's certainly a consideration. So I think the key thing is, a clinical trial in this instance is also always a good option because there are novel agents and things that are coming out. But I think it's really a discussion with your oncologist about how you did with the original therapies, but there are certainly options. Okay. The next question was for a low-grade, well-differentiated gastrointestinal neuroendocrine tumor with somatostatin expression, does octreotide suppress further metastasis as well as tumor growth? And in my case, the patient has a small bowel primary tumor that's been removed, but a metastatic tumor exists in the mesentery without carcinoid syndrome.
Yeah, I mean, I think definitely want to hear your comments on this, but if we're unable to completely resect the disease where we think that where we have still measurable disease, then I think putting them on octreotide as a first line makes sense to help limit progression. Whether or not that actually inhibits any metastasis, I don't think we have great data for that, but we certainly do have data that suggests that it's going to slow it down at least for some period of time.
Yeah, completely agree. Completely agree. And I think we all sort of extrapolate thinking that lowering cellular activity reduces metastatic potential. And we certainly think that's the case, but I don't think that's been proven. But yeah. With regards to the next question, this is a very interesting one. So are you aware of any non-Lutathera trials that include assessing the impact of well-differentiated mesenteric or when neuroendocrine tumors on the mesentery when surgery is not a good option? So I think we can actually use this as an opportunity, Dr. Rose and Dr. Chen, to talk about when do you guys when are you guys more hesitant to operate on mesenteric tumors, and why might be the case?
Yeah, I think the reason is mostly anatomic. Assuming the patient is a healthy person, so if the lymph node, and when we say mesenteric tumors, these are really lymph nodes that have been replaced by tumor. If it's around a major vessel, so much so that removal of that vessel would compromise the ability of the rest of the intestine to survive, then it kind of comes down to a technical reason. So it's about location. So if it's a lymph node that spreads so far down the mesentery that it's on the major blood supply supplying all of the small intestine, well, you can't remove all the small intestine and still live. So it becomes a technical challenge.
Yeah, I'll just add to Dr. Rose's comments. I think that as he mentioned in his talk, is very individualized, meaning that, the reason to take it out or not take it out for each patient is going to vary based upon, how much hormone is producing if the patient has symptoms from the lesion, for instance. And a lot of times different surgeons will give you different opinions. And so I think the second point is, as Dr. Rose pointed out, it's important to see someone who does a lot of this, or a center that has a great multidisciplinary team to discuss your overall management, because you may find that the willingness to use surgery is going to be different depending on where you go.
Yeah, I fully agree with that. I think the comfort level of the surgeon on how far down on those blood vessels and how comfortable they are working around them is going to change your recommendation as well.
Mm-hmm. And if I may chime in as well, so it's interesting in that, mesenteric or bulky tumors that line the mesentery that especially are close to blood vessels previously were considered actually even a contraindication to PRRT. Now, we actually think that that might not be the case anymore. So I know we and several other centers are doing this, but we've actually been using steroids, kind of peri-treatment. So we'll do dexamethasone a few days before PRRT, the day of PRT, and a few days after, to prevent complications such like a tumor flare that can cause ischemia to the bowel or bowel obstructions, and have thus far had pretty decent results. But I think to Dr. Chen and Dr. Rose's point, it's a very individualized discussion, but certainly mesenteric tumor deposits are something that always comes up on our tumor board, and I think we all try to be thoughtful about who should get what therapy in that instance. Okay, so with regards to the next question, so after surgery to resect some liver lesions and debulk others via ablation, sandostatin is often employed with periodic scans to monitor the activity of residual tumors. When scans eventually show evidence of tumor progression, how do you decide whether to do a second surgery or PRT for the next step in management?
That's an outstanding question. And I think that comes right back to that point of having a team approach to this, a multidisciplinary team approach, because going now on to second cytoreduction and debulking surgeries after getting PRT, we're getting outside the realm of having any data to support us. And so it comes down to very, very, it's a patient-specific thing. It becomes, is this technically possible? What are the chances are that we're going to have a significant cytoreduction? And how healthy is their liver after it's received all this treatment?
Bart, you may want to also comment. I know your talk was you covered a lot, but you didn't talk much about resection of the liver, and some of the rules about when do you resect, when do you ablate, and maybe you want to comment a little bit about that.
Yeah, sure. And I think I didn't. It's a very. It deserves a talk of its own. I think the thing on when to resect and when to ablate is a lot based on the anatomy and then the amount of tumor that is present in the liver. So there's, as far as it goes with debulking procedures, cytoreduction, probably 70% reduction gets some survival benefit is what the newer data is suggesting. You can get at 70% of the disease that probably has a clinical benefit. And you need to be able to leave enough liver behind that the patient can survive. And for most healthy livers, that's going to be somewhere between 20 and 30% liver, and then it will regrow. So you do a combination of resection and ablation. Usually I will do resections if it's a large tumor involving one anatomic part of the liver, or it's a small surface thing. And then for the deeper stuff, if there's small tumors, and that's where the ablation goes, because you really want to save as much healthy liver as possible. One, to give it a chance to regrow, and then two, because you know that this is going to be coming back in the future, and you want to save enough liver to do this again if you have to.
Yeah, and I think the question about when to sequence PRT is a very individualized decision as well. So, some of the data that we have presented, does suggest that earlier incorporation of PRT is better, but it also depends on pattern of progression. So, for example, if tumors have only grown in the liver, even liver-directed therapy is certainly an option. And so I think, really determining where the pattern of progression is crucial to that aspect, because in many times liver-directed therapy can be given and we can avoid PRT until down the road. So, I think there's a few different ways to approach that situation. So this is a question for Dr. Rose and Dr. Chen. So can robotic surgery be employed for liver resection or ablation to reduce incision size for follow-up surgery?
Yes. So I think either robotic or laparoscopic. The difference between the two is just who holds the instruments. I tend to like to do robotic surgery if I can, just because it's easier on my back. But the actual, the incisions are the same, the techniques are the same. If you've got somebody who's comfortable doing minimally invasive liver surgery and thinks that they can get good clearance, then I think that makes sense.
No, I think of course, you're totally right. I think there's a lot of perhaps misconception about the robot versus other minimally invasive techniques, and really the results for using a robot versus our traditional minimally invasive techniques are about the same for liver surgery. So there's no really big advantage for the robot than what we call laparoscopic. I think the most important thing is that you want to make sure you do a good operation, a good resection. And most of the time, if the surgeon is expert, has skills in minimally invasive surgery, they can do that minimally invasive. But there are going to be times where the surgeon can do a better job doing a traditional open operation. And I would think in those cases, that's what should be done.
Yeah, that's exactly right. It comes down to safety, and you never want to do anything to push boundaries if you don't think it's going to be safe. So I caution all my patients, I'm willing to try to start minimally invasively, but I will convert to open very quickly if I'm not comfortable.
Great. The next question I think I can take. This is with regards to PRT, how should we think about the risk for leukemia? Are there any anecdotal evidence or subgroups that have disproportionate risks for this, such as those who've gotten previous CAP-10, sex, race, and what can be done to mitigate the risk? This is really a fantastic question. So, one clarification I'll make is that fortunately the risk of leukemia with PRT is actually a lot lower than that. The risk that I think is being cited at about 2 to 4% is actually myelodysplasia or bone marrow changes. Now, that doesn't necessarily mean it's a malignancy in the bone marrow, but rather that the bone marrow can show changes from the radiation effects. The risks of leukemia are much lower. They've been cited at 0.1%. Some series have even said lower. So that is fortunate. However, the second point about how do we identify subgroups of patients that might be at higher risk is a fantastic one. We have actually some of our blood doctors looking at things like CHIPs, which are basically these mutations that are present in all of us that aren't cancer causing, but may cause vulnerability to certain therapies. And there's a lot of interest in studying, are there certain CHIPs that can predispose patients to certain leukemias or bone marrow changes from aspects like PRT? So that's a hotly debated issue, and one that I think we'll get more insight on in the future. But with regards to mitigating risk, I think one of the things that I always tell my patients is we always have to be very thoughtful of therapies prior to PRRT. So, for example, with capecitabine and temozolomide, for example, I never continue it indefinitely because of that worry that an alkylating agent can have on the bone marrow and cause some irreversible changes or low enough platelet counts that would make PRRT so risky. So I think it's a combination, but I think it's certainly something that we all have to learn more about to recognize who not only is at higher risk, but can we actually give PRT differently? Can we give, for example, 2 doses to someone rather than 4? Or can we give half the dose to patients rather than full dose? But these are still sort of active questions that are being determined. Okay, now I think we'll move over. So we have a bunch of questions in the Q&A. So, all right, so this is for our surgeons. So is an endoscopic resection a possibility for pancreatic tumors instead of having to have a Whipple operation?
If it's in the pancreas, no. Now there are some investigations in single centers looking at doing endoscopic procedures to address them. So not resecting them, but putting needles into them and microwaving them to kill them, putting in needles to do something called irreversible electroporation. The data on that is not strong, and it also there's significant side effects with those. I think that would typically be done in somebody who wouldn't be a candidate for an operation otherwise. And again, it comes down to, if you're removing it, it's either because of a symptom or because you think it's cancerous. And if you think it's cancerous, then you need to get those lymph nodes out. And by just sticking a needle in it and burning it, you have no idea what's going on with the lymph nodes, and you're never going to remove them. So it's really, in my mind, inferior for a cancer treatment. Great.
The next question is a really important and good one. And so this is, can you talk about pregnancy and a metastatic small bowel neuroendocrine tumor, a patient with metastases to the ovary? So, I think honestly, this is, and I'll open it up to everybody, but this is a very challenging area of management, just because, many of the drugs that we use to treat our patients with neuroendocrine tumors have not been shown to be safe in pregnancy, or there's just not much data. So I could tell you from our personal experience, for example, with Sandostatin or lanreotide, typically we avoid it, especially in the first trimester, if we can, for patients that must require treatment. What we love to do is to have patients, deliver their babies before thinking about further treatments. But if someone needs treatment, we think about trying to put it in the 2nd and 3rd trimester. But of course, it's something that we have to work closely with our gynecologists with to get further input and see what may or may not be safe.
Yeah, I think this isn't something that I'm going to have a lot of expertise in, but if there is an urgent operation that's needed, then we can often do that safely, say for a malignant bowel obstruction or something in a pregnancy. So from a surgical standpoint, there may be interventions that can be done safely, but I think most of those risks are going to be associated, like what you said, systemic treatment, chemotherapy, PRT.
The next question is about, it's a treatment question. So it's, what treatment would you advise for someone with an insulinoma, who had a distal pancreatectomy, splenectomy, and liver debulking, and 9 months later has progressed in the liver, now experiencing hypoglycemia again? So I think I can start with this, is that I think we certainly, you mentioned that the liver has progressed, but I think it would also be important to see if and where else the tumor has progressed. So this would be an important time to perhaps get a dotatate scan to kind of assess the pattern of progression, because I think that could then guide what we think about. If it's perhaps an isolated tumor in the liver that's growing, that's causing this, we could think about liver-directed therapy, whether that's ablation, even debulking potentially. If it's more of a globalized pattern of growth, I think we would think about some of our systemic therapies. So thinking of things like CAPTEM, or even, the reason I said CAPTEM rather than a somatostatin analog is we have to be careful. Sometimes the somatostatin analogs can also worsen hypoglycemia. So that's something that's plus or minus. But I think we just have to determine whether treating systemically or treating locally is the right thing in this instance. Happy to get your guys' thoughts.
Yeah, I agree. I think it depends on how much progression there was and where the disease is. Is this one single lesion? Is this multiple? We do have medical treatments that can kind of shut down insulinomas and manage these medically beyond just systemic treatment. They have significant side effects, but sometimes that's safer than being significantly hypoglycemic.
The next question is just more of a general question for you guys about what value does a EUS have in just, I guess, surveillance, tumor diagnosis, or routine screening for neuroendocrine tumor patients?
Yeah, so endoscopic ultrasound or EUS is going to be helpful for patients who have neuroendocrine tumors in their foregut, meaning stomach, duodenum, pancreas, because that's really as far as the scope can go. For making the diagnosis, I don't think it's particularly useful often. If you have good quality imaging, you can usually make the diagnosis based off of that. If the diagnosis is in question, then maybe that makes sense to get a tissue biopsy. For surveillance, I don't see, unless you can't see it on CAT scan or MRI scan, I don't see utility in following it with endoscopic ultrasound.
Great.
Yeah, I totally agree.
Great. All right, so this is an interesting question. I think it's a management one. So this is a patient who has a neuroendocrine tumor. It's 1.4 centimeters. I think our surgeons are going to ask where this tumor is located, but how would you guys manage a patient with a localized neuroendocrine tumor in the pancreas that's 1.4 centimeters?
Yeah, again, it depends on where
it's functional or not functional.
Yeah.
I guess would be important to know, right?
Mm-hmm. So we don't quite know that, but let's see if
yeah, exactly. So that's gonna, if it's functional, then and it's resectable, then we would resect it for symptom control and potentially to control metastatic disease. If it's non-functional, it's in that window of, it's kind of that gray zone. So we would probably follow very short interval surveillance for a little while, see what the growth rate is. That may be something, again, depending on their age and their overall health status. I will get an endoscopic ultrasound in this range sometimes to look at the grade of the tumor, because if it's a grade 2 tumor, then that's something I may resect in that gray zone because they're more aggressive. But I wouldn't necessarily do that in somebody who was 85.
Yeah, I would agree with that. You know, there's certain patients with that are older, have other comorbidities that actually, you know, their tumor is slowly growing, still less than 2 centimeters. They sometimes will just actually even treat them with the somatostatin analog to sort of freeze growth. So I think it's definitely an individualized decision based on tumor and also, actually more importantly, patient features. So next question I'll take, we'll briefly, it says, can pregnancy occur and the consequence on hormone therapy to harvest eggs? So I think this is probably beyond, you know, all our wheelhouses a little bit, but we do have patients that actually get pregnant while on a somatostatin analog, so that can certainly happen. But I would have to defer to, you know, probably our reproductive endocrinologist or gynecologist for that question. With regards to the next one, so recommendations for monitoring a 3.5 centimeter atypical bronchial carcinoid, which had grade 1 features, though it was atypical, had lymph node involvement, and it seems that the patient had a lobectomy and has no evidence of disease recurrence. So at 13 years, I guess the question is, would you continue surveillance or would you not?
I'm a little bit less familiar with the bronchial carcinoids. It's going to be our thoracic guys, but for most instances, if you've had no recurrence within 10 years, the likelihood that it's going to come back is extremely low. I stopped surveilling all my patients after 10 years.
I would agree with that as well. I think the one caveat here is that it's an atypical lung neuroendocrine tumor, so atypical lung nets can at times behave more, but here in this instance, we have the test of time, so I'd be pretty comfortable stopping surveillance as well, unless something developed. Okay, the next question is about effects upon drugs on chromogranin. So can barium have an effect on chromogranin A?
I've never seen that, but Dr. Chen is a chromogranin expert.
I'm not sure. So you're talking about like barium that you use in a radiologic study, I think, is that what they're asking?
I think that's what's being asked, yeah.
Yeah, I've never heard about barium changing chromogranin A levels, but quite honestly, I'm not sure I've ever checked.
Mhm.
It's true.
Yeah, no, exactly. I'm the same way. I think, the chromogranin A it's valuable in some cases, but it can rise due to so many different reasons, including the most common medication class is proton pump inhibitors, which oftentimes many people are on. So sometimes, most of the time we actually don't check it, but it's an interesting question. All right, so I think we spoke on the next question, which was what are the typical recommendations for a well-differentiated, this time as a 1.4 centimeter pancreatic neuroendocrine tumor? And I think our surgeons had said that if it can be resected and it's in the right patient, probably to go ahead and resect it. But to otherwise think about some of the things we talked about in the other question. But any other thoughts from you guys?
Yeah, I mean, again, it kind of comes down to the location, the anxiety of the patient, family history, a lot of factors. But that gray zone 1 to 2, I don't usually jump right into resection on anybody. I'll at least do some short interval surveillance unless it's a grade 2 tumor, and I know that going into it, or there's any other high risk features about it. I think most of these are very safe. There was just what's called a meta-analysis, meaning looking at all the studies that have been done to date and boiling it all down into kind of one study, looking at how likely is this to spread to lymph nodes at these different sizes. And less than 2 centimeters, it doesn't really change the chance of spread. It's when you get over that 2 centimeter mark, for whatever reason, seems to be a magic number in neuroendocrine tumors for risk of spread.
Great. So next question I'll take. This is in the RADIANT studies. So in the everolimus studies, just patients in the studies, were they all treated with the 10 milligram dosage, or were there patients that had to undergo dose reductions to 7.5 milligrams or 5 milligrams? And how should we think about effectiveness at a reduced dose? Great question. So there were absolutely patients on the study that were dose reduced. And because of actually the toxicity of everolimus, for the most part, I actually start most of my patients on the 5 milligram daily dosing because 10 can be quite toxic. So I think there's certainly activity at 5 milligrams, or actually even I think there were some patients on that study that were also treated at actually 5 milligrams every other day that still demonstrated benefit. So I think it is absolutely a drug that can be dose reduced, and I think the more important aspect of the drug is being able to get the drug rather than to be at a dose in which you can't get the drug. All right, so the next question was regarding dose escalation on a somatostatin analog. So knowing that somatostatin analogs cause hyperglycemia and can increase blood sugar, when patients are on a maximum dose of somatostatin analog, is there anything that can be done to reduce the chances of developing diabetes? So, I mean, I think, it's one of those things that it is a challenge, right? Is that we do know the higher we go on a somatostatin analog, oftentimes blood sugar can be more challenging to control. I think the key thing is we work oftentimes very closely with our primary care colleagues to help titrate regimens or working on other things like whether it's weight loss or more aerobic activity to try to mitigate that. Sometimes it is a question in folks that are pre-diabetic that an earlier incorporation of a drug like metformin, but that's really something that we work with our primary care colleagues to manage, knowing that it certainly is a risk. And I think those were, or thus far, those were our active questions. We're happy to take any further questions from you guys.
Hello, everybody. Figured I'd join in here. It looks like we ran out of questions, so if you have any other ones, please type them in the next couple of minutes. And if there are no other ones, or if you come up with another question and we've already ended this Q&A, there'll be another Q&A at the end of the afternoon, later on this afternoon. So we may be able to catch them there, or you could always email bob@netcancerawareness.org, and I'll spread it out to see if we can get an answer from the panelists if they have an opportunity to answer that. But looks like we might have had one question come in.
Yeah, this is actually a great question. So with this, this is about, all right, a few more coming in. So this is about the best FDA-approved scan to monitor for recurrence.
Yeah, I think that's a great question. I think we're still trying to figure out the role of dotatate in recurrence and surveillance. I don't really have strong evidence for doing this, but what I've been doing for my patients that I think are a high chance for recurrence, either had positive lymph nodes or were grade 2 tumors, higher Ki-67s, is I'm alternating between CAT scans and dotatates. So I kind of get a CAT scan very quickly after an operation, usually 3 months, 6 months. And then a year after the operation, I get a dotatate, and then I get a CAT scan 6 months after that, and then a dotatate 6 months after that. And so I'm kind of flip-flopping between them for these higher risk patients.
Yeah, I mean, I think it's very much individualized also as to where the tumors sort of originally were as well. I oftentimes just use CT or MRI for surveillance, only using a dotatate if there's a question. But I think there's certain tumors that are less visualized on CT and MRI, and a dotatate may be necessary. So I think it's definitely something that's emerging and an active question. All right, this is an interesting question, a little bit of a loaded question, but the utility of the NET test to assess possible progression. So I can start with that a little bit. So the NET test is a blood test. It measures actually mRNA transcripts of certain genes that neuroendocrine tumors are associated with neuroendocrine tumor growth. This is a test that has actually been validated in a number of cohorts now, looking at, if the NET test rises, it's not a single value, so it can change. But if a NET test rises, should we change our treatment management earlier, or can it indicate, sort of recurrence? So I think it's still, though it has been validated, the NET test is still not available everywhere commercially. So I think there's still a lot of questions about, do we really need a NET test to tell us about progression, or can we tell just based on how the patient in front of us looks and the scans that we already have? But we're curious to get your guys' thoughts.
Yeah, I think it's one of these things too that you have to ask yourself what you're going to do with that information. As we get more and more sensitive for detecting recurrence, but we don't have any evidence of where the disease is, what do you do with that information? You just put them back on systemic treatment, not knowing where the disease is. You can't really operate on something you don't know that it's there. So I think we're still trying to figure out how to use some of these molecular markers wisely.
Yeah, I often can make a comparison to another cancer that I treat, thyroid cancer. A lot of times we can detect a recurrence by the blood test. In that case, it's a relatively inexpensive blood test. And if we can't find the tumor, we generally, don't treat it, especially if the patient is asymptomatic. So I think I agree with both of you. It's just finding the context, and when you have the information, is really going to change the management, which you have to ask if you're going to utilize it.
Great. We can kind of couple two of the questions together. So what can cause pancreastatin to rise? Is it a reliable marker? And the concomitant question is, just in biomarkers in general, what importance or dependency do you place on the chromogranin A or other markers?
So I don't use pancreastatin. I do use chromogranin mostly to follow patterns of change. I don't think the actual absolute number means much. And like you said, it can be elevated with a number of things, very common things, being on antacids. But I do, if I follow somebody and they had a high one before an operation and then it goes to normal and then it starts coming high again, then that may be something where I would step up the surveillance interval if I don't see anything on the imaging.
Yeah, I would completely agree with that as well. And I as I was telling you guys earlier, I don't routinely check chromogranin. One of the biomarkers that I use more regularly for patients with actually functional carcinoid tumors is a 5-HIA level. So I do actually I've converted to plasma 5-HIA levels, and that helps look at the activity of the tumor, and it's something that I found quite useful as well. And then this was a follow-up question to the patient that had mentioned, the patient that had undergone a distal pancreatectomy as well as substantial liver debulking, I think with the insulinoma, and the tumors that were the residual ones were the ones that grew slightly. would you still require a dotatate PET before proceeding? In that instance, not necessarily. If we're seeing slight growth of the tumors that are left over, I think it would be reasonable with that imaging to actually think about liver-directed therapy to see if those few tumors that are growing could be taken care of without needing a systemic therapy. Okay, so I'm sorry, go ahead.
I would just add that the other thing that makes a difference too is the time frame, right? If this was 5 years later and it grew slightly, that's different than 5 months later. So, if it seems like it's a more aggressive thing, there's been a fast progression. If they've been on lanreotide and grew on lanreotide versus they've just been watched and now they haven't, then maybe it makes sense to put them back on lanreotide. I think there's a lot of factors there that go into it.
Yeah. Okay, great. This will be our last question before we hand it back to Bob. So if a patient has well-controlled liver disease on Affinitor for 3 years, is it reasonable to test the lower dosage? So, I certainly think it is, but I also think it depends on the side effects that you've been experiencing over this period of time. If you've actually tolerated it quite well and it's working, it's not unreasonable to continue. But I, in general, am a fan of lowering the dose if and when it's needed, particularly if things like mouth sores or fatigue arise commonly. But I think it really depends on kind of how you've been tolerating the drug to begin with. So yeah, I think I'm gonna hand it back to Bob so we can keep moving, and I think there'll be some other Q&A sessions as well for us to answer some of the leftover questions. Thanks.